All right. Well, good afternoon, everyone. My name's Garth Reynolds. I'm the executive director for the Illinois Pharmacists Association. And what I want to make sure that we go through today would be a very brief overview of what to expect for Illinois Pharmacy Legislative Day for this year, which, if you're not aware, it is a joint event between Illinois Pharmacists Association and the Illinois Council of Health System Pharmacists. We have done this program jointly now for almost 20 years. I believe this is our 19th year doing this together. I'm really glad to see both organizations coming together and our shared advocacy goals as we try to address the myriad of issues that impact our profession and our opportunities to educate policymakers on the value of pharmacists. And so I do want to kind of go over some very quick points as we go through today, because I know many of you who may have never have heard any of our previous advocacy or law-related presentations, or just may not be familiar with the process or been at a legislative day. And that's one of the reasons why we have this program today. So this is the quick and easy process of how a bill becomes law in Illinois. I am going to step through this, but we're going to use a very quick example. We're going to do a quick idea that a legislator may have that would say that all pharmacies in Illinois would have to close on Sundays at 6 p.m. And they can introduce that, and for our purposes of our example, it's going to be a representative. So this is going to be submitted and introduced into the House. Now, a bill can start in either the House or the Senate. It doesn't matter which way. And so the idea gets drafted and sent to what's called the Legislative Reference Bureau, or you may hear us refer to it as LRB. And LRB is a team of attorneys that take all these ideas, these thousands of ideas, literally thousands of ideas that come through the General Assembly, whether from legislators or from advocacy organizations like IPHA, and help put it into a format that would comply with Illinois law. And that gets introduced and gets sent back to the representative. The representative would send it, in this case, send it over to the clerk of the House to have it read for the first time. And I use that read in quotes because every bill is read or processed and presented 3 times. This first time it's presented, it gets assigned its number and gets read its short title. So if this bill example, like I said, is going to have all pharmacies closed at 6 p.m. on Sundays, is a bill amending the Pharmacy Practice Act, and that means it's considered to be a bill of regulation. So for our purposes, the clerk would receive the paper from the representative, assign it House Bill 100, a bill concerning regulation, and that's considered to be the first time it's read. Now all the bills go to the Rules Committee in the House. In the Senate, it's called the Assignments Committee. This committee takes all the bills. So think of it as these committees as almost like a giant bucket that go through and filter all the bills and decides which committees will hear these bills to see if they meet qualification to move forward for consideration. And the Rules and the Assignments Committee are chaired and made up of leadership from both the majority party and the minority party. And in this case, both the majority parties in the House and the Senate are democratically controlled, and the minority party is the Republican Party. And so in the House, we have a number of committees that this bill could go to, but it would be assigned to House healthcare licenses because it's a bill that would amend the Pharmacy Practice Act. Now, the committee process allows for a small group of legislators to validate a bill to see if it meets their approval to go forward to the floor for the entire chamber to consider. And from our point of view as an advocacy organization, this is the best place to either amend a bill, to change it, to support a bill, or to kill a bill, because we only need to influence so many votes. Like they're still working on the complete makeup of this year's committee, but last year's committee had 8 people in it. So we only needed to ensure that we had 5 votes on our side for whatever that was for the bill, either amending it, supporting it, or opposing it. And that's a lot easier to do in working and advocating and lobbying 5 individuals versus needing to do 60 or more when it gets to the floor. And so in this example, the committee of the House Healthcare Licenses Committee would hear testimony on the bill on the pros and cons for why it would or would not be good for all pharmacies to close at 6 p.m. on Sunday. They decide there's no need for amendment and they want to approve it to the floor, so they move it due pass. Now this now takes the bill to the full floor for what's called second reading. This is the second and last time, at least in this chamber, that a bill can be amended. Usually amendments are handled in the committee, like I just talked about a couple of minutes ago. But it can be done on the floor. And usually they're technical amendments, like they forgot to add an effective date or something like that. But once it's done through second reading, there's no amendments. It goes to what's called third reading, and this is the final reading stage. Now, when third reading happens, third reading is what you normally think of when you think about the House or the Senate, whether it's on the state level or on the national level. This is when legislators will actually debate the full merit of the bill. And this is when you see them on TV when they're arguing or debating about a piece of legislation. Well, in this case, the bill is debated. The House completely agrees with it and votes it 118-0 to pass. Now it goes over to the second chamber. In this case, it goes over to the Senate. Now, you would think because it went through all that process of going through the committees, that it would then just go to the floor of the Senate because the House already approved it. Well, the Senate says, as part of our checks and balances, we get to have the same right to take that bill through that entire process again. So it goes to that Senate's Assignments Committee, again, that big bucket committee. The leadership of the parties decide what committees it should go to. In the Senate, it would go to a committee called Licensed Activities because the Senate doesn't have as many legislators as the House, so they have to combine some of these committees together. So Licensed Activities takes a look at the bill, but in the meantime, advocacy organizations and or pharmacies had reached out to members of this Licensed Activities committee and said, we actually think that this bill should be amended to say all pharmacies would close at 6 p.m. on Sundays, except for health system and long-term care pharmacies, because of their need to be open longer than 6 p.m. The committee agrees with that, and they move it to the floor of the Senate. There's no further amendments to second reading, and it now goes to third reading for its final debate. Senate likes its perfected amended bill, and they decide to vote on it 59-0. Well, normally, if this bill had not been amended, it would go to the governor because we now have a bill that's passed both the House and the Senate. But as you know, we now have a bill that's two different versions. We have the original version from the House that says that this bill would be for all pharmacies closed at 6 p.m. on Sundays. And the Senate's version says 6 p.m. on Sundays for all pharmacies except health system and long-term care. So we have to go through a process called concurrence, where just the amendment goes back to the House that says, do you agree with the changes that the Senate made? And they go through and they debate that, and in this case, it goes forward. So now we have a perfected bill that goes to the governor. And the governor, similar to the president, has the right to either approve a bill or to veto a bill. Now, unlike the president, the governor in Illinois has extended veto authorities. So the Governor Pritzker could take a look at the bill and say, I don't like this entire bill. I send it all back. Or the governor could actually look at it and do what's called an item reduction veto. And say, you know what, I appreciate what's being done here, but I think 6 p.m. is a little too early. We're going to change this to 8 p.m. Or they can do an amendatory veto, which is almost like a legislative authority for the governor. And the governor can put in with additional rationale saying, you know what, I love this idea about 6 p.m. For all pharmacies except for health system and long-term care. We're going to make this across all throughout the week. So every day it's going to be closing at 6 p.m. Now, for that to go into effect, the House and the Senate both have to override that governor's veto by a 2/3 majority. And it's also called a supermajority. And we'll talk about here in a minute how the Democratic Party has that numbers to be able to override that veto. We don't get into this situation too often. A lot of times, our General Assembly works very well with the governor's office for the most part, and so we don't see too many vetoes that happen. But in this example, the governor decides that he approves of the bill as it was presented. So all pharmacies would close at 6 p.m. on Sundays, except for health system and long-term care. And so that's a quick, very quick example of how a bill would become law. Now, of course, there's rules that can kind of help maneuver bills around this directed process. But because sometimes bills are like patients, they don't always want to stay within the guidelines. But that's also why it's very important that we have organizations like IPHA and ICHP and some other pharmacy stakeholder organizations keeping an eye on what's going on in Springfield. So let's talk about the 104th General Assembly. That's our current General Assembly term, and it is a 2-year term, and they've just started that back on January 8th of this year. Currently, our makeup is we have 59 senators, 40 of them are Democrats, 19 are Republicans. And we have 118 representatives, 78 are Democrat and 40 are Republican. So, like I said, the Democrats have a supermajority, so they have enough members that they're past the normal 50% majority, but they also have enough to override a veto in the case that that would occur. So, the Republicans don't have enough members to be able to override a vote, but that doesn't mean they don't have a voice. And so, despite what sometimes the parties may exclaim, there is a lot of negotiation and compromise that goes on with the majority and the minority parties, regardless of their numbers at this point. So, our General Assembly historically is very active, and especially since we need to look at this from a healthcare policy point of view. And about 85 to 90% of the regulations that you will utilize on a regular basis in your day-to-day pharmacy practice are based off state legislation. And this is why state advocacy and being part of your state association is so important, because it's the state legislators who decide how you practice pharmacy. And so, with that being said, we're still within the initial filing period. And so they've already filed 4,300 bills. And actually, I just looked right before I logged in for this call, and they've already filed another about 125 bills for today so far. And they have until Friday to get the initial rounds of filing completed. With all that said, we usually end up monitoring well over 300 bills per any given session. Now, not all of those are high priority, high risk bills to the profession, but all the bills that we monitor in some fashion impact how we would practice as pharmacists or impact patient care or public health. And so we do take a look at those very seriously. And with that, this volume of legislation, our legislative committee meets on a weekly basis to go through how things have changed, what strategies we need to implement, and we discuss with our lobbyists on how we should proceed. But as I stated earlier, the General Assembly is a 2-year term, so this term will go through until the end of December of 2026. And this is very similar to the timeline that Congress is in. Congress just instituted the 119th Congress on a federal level. Now, not all states are in that same term. It just happens to be a coincidence that Illinois is the same as federally as Congress. Now, we talked about committees when we were going through our example, and this is not a all-inclusive list, but this is a list of the majority of committees that we deal with on a regular basis. And I would say the ones that I have highlighted here are ones that we talk to the staff members on almost on a daily basis during session, and depending on the week and the bill load. So in the House, we have the Appropriations, Health and Human Services Committee. So that deals with any bills that may impact the state budget, particularly Medicaid. Healthcare licenses, we already talked about. Healthcare availability and accessibility and prescription drug affordability are some newer committees, and they actually focus on a lot of our PBM reform legislation. And then in the Senate, they have a similar Appropriations, Health and Human Services Committee, and then Insurance and License Activities are the committees that we worked with the most on the Senate side. Now, when a bill gets passed, that is not the end of the road for advocacy, because especially those of you who started to study your pharmacy law component, there's the Pharmacy Practice Act, and then there's the rules for the Pharmacy Practice Act. And rules are part of the administrative code, and those are developed by the departments. So we work with the departments under the governor's office on just as much of an equal, if sometimes if not more, depending on the issue, than working with the General Assembly. And so the Department of Financial and Professional Regulation, that's where the Board of Pharmacy is under. And so your licensure is all through that department. Healthcare and Family Services, or HFS, also known as Illinois Medicaid. Department of Human Services, one of the main aspects we work with them on is they administer the prescription monitoring program for all controlled substances. The Department of Insurance oversees all of our PBM and managed care regulations. And the Department of Public Health. We work with them on a lot of grant projects, but also on immunization monitoring, and also worked extensively during the pandemic, and now have been continuing our discussions on pandemic preparedness for the next one. And then lastly, Central Management Services, or Illinois CMS. And I know we talk about CMS in healthcare, but it is not Centers for Medicare and Medicaid on a federal level. Illinois CMS is actually the state's HR department. So any issues that we have that impact employee state plan or the retirees or teachers' health insurance, we work with Illinois CMS on those issues. And so with that, the rules, come about, like the Board of Pharmacy helps with directing rules for the Pharmacy Practice Act, and the department helps administer and propose those rules. Actually, we're getting ready to go through that process right now. And that process then leads us to an organization that's within the General Assembly called JCAR, the Joint Committee on Administrative Rules. And that's made up of 6 senators and 6 representatives, and 3 Democrats and 3 Republicans. So both chambers and both parties are part of this. It's actually one of the true bipartisan, bicameral committees that we have in state government. And so they help oversee all the rules that come through, work with the executive departments to ensure that the public is heard through its comments, and then institute and approve the rules once they're perfected. So this gives you an idea of a lot of the different aspects of legislative components that we help monitor that can be amended by the General Assembly or new rules put through, whether it's the Practice Act, the Controlled Substance Act, the Hypodermic Needle and Syringe Act, the Illinois Food, Drug, Cosmetic Act, all the way to the Cannabis Control Act. And this, I don't even have it included in here, but also the Illinois Insurance Code and the Illinois Public Aid Code. Those are all various components and extensive components of Illinois law that can have a direct impact in how you interact with your patients and deliver patient care. So even though we are still in that bill filing period, we have already started to identify some pieces of legislation that may have an hindrance or barrier onto how we practice pharmacy, and some where the General Assembly is wanting to help address some of the most vital issues impacting our profession. So let's talk very briefly about some of those. The first one is House Bill 1159, and this is addressing pharmacy benefit managers. And this has been brought forward by Representative Thaddeus Jones, who's also the current chairman of the House Insurance Committee. This is a very similar bill to a bill last year that the Department of Insurance and the governor's office was working on. So we expect this issue to come about, whether it's through this vehicle or another one, but addressing PBMs and how we need to prohibit spread pricing, curb the practice of patient steering, and ensure that rebates are going back to the health plan and to help actually drive down care, which is what rebates are supposed to do, not pad the bottom line of PBMs, which is what's happening now. But we're also needing to ensure that we have a proper reimbursement structure for pharmacy. We have finally come to the point, which is unfortunate for pharmacy and healthcare in general, that we finally have to say in law that pharmacy should actually be appropriately reimbursed for the medications that they dispense. And so we're asking for a reimbursement floor to be established. and a professional dispensing fee of $10.49 to be considered. And that number doesn't come lightly, because depending on the surveys, we should probably look at that number closer to $13 to $14. But right now, many pharmacies are getting reimbursed either zero or less than $1 for any of the medications. And that's if the medication itself was covered by its cost. Many prescriptions at pharmacies are dispensing right now are well under their cost, which is why we're seeing a lot more pharmacy closures. We had over 80 closures of pharmacies in Illinois last year. We had over 2,200 pharmacies closed across the country this last year. And we already had Walgreens announce 5 closures for 2025. So this has been an issue that's been continuing to build pressure for a number of years, and I would even see well over a couple of decades, where at pharmacy and patient care advocacy groups have been working with legislators on both a federal and a state level, talking about the need and importance to correct this behavior. And we've shown reports. The FTC, the Federal Trade Commission, has done 2 reports showing the mismanagement. Actually, I think, what is it? Over $7 billion in spread pricing just on specialty generics that one of the PBMs was shown to have exploited. In Illinois, we had a report done just in 2 years examining our Medicaid program that $200 million was kept by the PBMs that was supposed to go to pharmacies. So we've got to work on this behavior change and stop this exploitation of pharmacies, which create more and more barriers and access issues for our patients. These next 2 bills are bills that I call bills of good intention, because they're wanting to help increase cost, but they're not always looking at the ramifications to our patients and to the pharmacy profession. House Bill 1287 is another importation bill that we're looking at trying to allow patients to import out from Canada. There are numerous issues that are wrong with this, that because, again, we have issues with looking at international medications coming in. We have an extensive regulations on track and trace from the Drug Quality Security Act on a federal level that the entire healthcare system has to adhere to. So allowing importation programs like this actually expose patients to medication that may not be of the highest quality and could be of counterfeits, and it does not lower costs overall. Same thing with the healthcare availability boards, or also called pharmacy prescription drug affordability boards. Both of these bills are prime examples. If we really address PBM reform, we can actually address the issue where this actually continues to put regulations that actually end up burdening the patient and pharmacies, and actually the 2 least individuals who have impact on the cost of medications. And this would set up a board that would decide if a medication is expensive, and then would set a maximum price for that medication. 10 other states have looked at this, and the only one that actually has any progress of actually getting their board put together is Colorado. They spent $5 million to determine that Enbrel was expensive. Well, most of us that have any experience in community and ambulatory care pharmacy know Enbrel is expensive without spending $5 million to know that. But the big issue with this, and federally with the Medicare Fair Price list under the Inflation Reduction Act, if you don't enable a mechanism for pharmacies to be able to buy at this discounted price, this actually puts pharmacies at a further disadvantage for manipulation from PBMs, because they're already under reimbursing this medication. And if pharmacies continue to have to buy at the higher price and they're being reimbursed at a severely lower cost. NCPA just released a study this past week where it showed 93% of the respondents to the survey stated they're just not going to carry these medications because they can't afford it and be able to pass that on to their patients. And so what we're doing here is we're just setting up a list of medications that to let patients know that these are what medications pharmacies aren't going to cover. And if we're looking at the Medicare list, it's not medications that aren't being used. It's some of the most commonly used higher priced medications. And so like Jardiance and Eliquis. So we have to look at different mechanisms besides this type of legislation. The last example I want to show you is Senate Bill 1390. This is brought forward by David Kaler. And Leader Kaler has been a champion for PBM reform. And similar to the very first bill that we looked at, this is trying to address a lot of the abuses from PBMs and managed care organizations on the Medicaid side of the equation. We were able to take parts of this bill last year on adding some additional transparency authority to Medicaid into the state budget bill. So this is our continuing work in trying to, Leader Kaler is trying to save pharmacies and decrease the expansion of pharmacy deserts by ensuring a proper reimbursement pathway under Medicaid. So those are some very quick examples of some of the bills that we're taking a look at here. And really what we want to make sure that we're doing through Legislative Day is activating your voice when it comes to pharmacy. And there's many voices in pharmacy and in healthcare. And on the left-hand side are some of our sometimes partners, but sometimes adversaries. And it all really depends on the issue. And that's why on the right-hand side, we have really a strategic partnership between the Illinois Retail Merchants Association, which handles they advocate for any businesses from grocery stores to gas stations to major multiple department pharmacies like Walgreens, CVS, Osco, Walmart, and Mariano's and Kroger. And I would put Ivy and even Meyer into that on the corporate side. So they work in partnership with us between the Illinois Pharmacists Association and the Illinois Council of Health System Pharmacies. And all three of us meet on a very regular basis, sometimes more than once a week, on these issues that are impacting the profession and ensure that we're in a coordinated action to addressing these issues, because we have worked very hard, especially over the last 13 years that I've been in this position as the executive and before when I was a volunteer leader, and ensuring that we have a coordinated together strategy, because we've been able to accomplish so much more working as partners instead of working against each other. So how do we advocate? How do you advocate? And the first thing you can do is attend Legislative Day. We could also be supportive of a pro-pharmacy candidate. That's one thing I always try to have in our discussions here. Pharmacy is not a red issue. It's not a blue issue. It's as our chair of our political action committee puts it, it's a pro-mortar and pestle issue. Pharmacy is a very interesting uniter amongst usually political enemies. We have probably the most MAGA legislators you can think of on the Republican side to the most progressive individuals on the left-hand side of the equation, and they're all pharmacy champions. And so PBM reform is probably the most uniting issue I have seen on both a state and a federal level. And so coming together, showing how we can save pharmacy, how we can increase access and lower costs and increase outcomes helps bring people together. So we need you to be helping us with that mission and, working for candidates, whether it's working for their campaigns, doing simple things as going door to door or doing virtual phone calling, hosting a store visit if you have the opportunity to work with your practice site on that, and just simply writing a legislator. Yes, sending an email, they do read through them. It can help. And so when you meet with your legislator, and we'll go over this at Legislative Day, again, introduce yourself. We don't have a lot of healthcare professionals in our General Assembly. I think right now we have an anesthesiologist, we have a semi-retired optometrist, and a chiropractor, and one social worker, clinical social worker. Everyone else is a mixture of farmers, attorneys, and educators or other industries. So they look to IPHA, but they also look to you. That's one of the things that you can be. You can help with bringing more information to these legislators about how these issues impact your patients, because that translates to their voters. And so again, always look at these sessions as short conversations. Consider it like patient counseling. You don't sit down with a patient who's just found out that they now have type 2 diabetes and explain everything about diabetes in one session. You take little bits at a time You work through with actually even using motivational interviewing techniques in some ways, but it's education. And that's what we do from an association level. We help educate the legislators, educate their staff, and help with moving our issues forward. So we keep these discussions brief. We try to leave them with some bullet points on high points of the issue, and always remind them that we're there to be a resource for them. And it's always good when I talk to a legislator and I start discussing these issues. They're like, oh, I've talked with so and so in my district about this already. This is really important. And so it's really good as we have this supportive pathway of helping make sure that we educate these legislators to help advance our causes. And of course, when we're meeting, we don't want to be threatening or rude. We don't want to have any greater influence or try to bribe them in any way, we or bring up past campaign contributions. We just want to say thank you for your support, whether it's for or against, because sometimes they will not be for you. And that has to be okay. And that's one thing that's also really difficult sometimes, because especially in our polarized environment where it's either people are all for us or all against us, we have had many examples, and I can think of a number of examples over the year where somebody who is our strongest opponent was our bill champion the next session. And so you always have to look at it, working every issue is working every issue. And you keep trying to educate and reform their thinking and getting them on the right path. We've taken people who didn't understand how PBMs were hurting us and thinking that we were the manipulators to showing them the data, getting them into the pharmacy, and now they're the ones that are taking the PBMs to task in hearings and on the floor of the House and the Senate. So advocacy is extremely important, but it's so easy for you to take those first initial steps and in being a voice for your profession and for your patients. So legislative day can be a little bit of an organized chaos, but we work you up by taking you into different groups because we're not going to be the only group there. This picture's a great example. Unfortunately, for a number of years, we kind of went the same day that one of the gun rights organizations was there. And so that's a lot of people. There's a lot of energy behind that. But we try to gauge our days so that we're a little different from some of the larger groups. But there may be some larger groups that are going to be also trying to get attention of the senators and reps while you're there. But that's okay because we're going to help make appointments for you. Our lobbyists are going to be taking your registrations, putting you into groups, and there will be at least one individual who has done this before, and they will be working with you to help encourage you to have those interactions with your legislator. So again, we can make a difference, and it all starts with having that initial energy to stay, I want to talk to you about this, and saying hello to your senator and your rep and starting that relationship and building that voice forward. So again, legislative day for this year is going to be on February 26th. I encourage all of you to come and attend, and I'll be glad to take any questions that you might have. On this slide here, this is actually from last year's slide deck when Chris and I were doing this as a tandem, but here's my contact information if you need that. And also Chris's is here as well. So I can now take any questions that you might have.